So I am very happy to see you, everybody. Hello to everybody, Sherry Antoine, Sherry Eki, Sherry Bruno, ciao, Andrea, and of course, hello, hola Isabel, hola Soledad, hola Iris, legal professor Jürgen Wendler, hello. And we shall begin, and also our guests, Deborah, Maria Isabel, Nicolas, very welcome to this 15 online academic session of Collegium Medicum Theatri, and Liber Joseph, hello also. So if I miss somebody, please, I shall say hello after this first presentation. So I welcome you to our 15 online academic sessions. And as you know, we have been presenting many very interesting presentations and experiences from all over the world from our dear Collegium Medicum Theatri members. Hi, dear Rod, I am glad you are here. Please, Carlita, Ronald Scherer is also panelist. Hola, Gustavo, and we shall begin with our presentations. Silvia is also a panelist. Ciao, Silvia. Bienvenuta, Silvia. So we shall begin with our program, dear friends. And this is a great pleasure to talk about a very dear friend, Professor Dr. Berit Schneider-Stickler. She studied human medicine and music in Berlin, Germany, and also in other parts of Germany. She is ENT specialist at the ENT Phoniatrics Department Clinic of Charité in Humboldt University in Berlin, and also in the University ENT Clinic in Essen in 1998. She is doctorate in phoniatrics with the work classification and diagnosis of functional voice disorders. She habilitated on the clinical relevance of videostroboscopy in the assessment and differential diagnosis of voice disorders and received the venia docendi at the medical faculty of the University of Vienna. She made singing studies at the Hans Eisler Academy of Music in Berlin. She has many research stays at the University of California in the Irvine and the University of Wisconsin-Madison. She has been deputy head of the departments of phoniatrics logopedics at the Medical University of Vienna. She has many assignments in teaching at the University of Music and Performing Arts in Vienna, at the Institute Antonio Salieri, and at the Academy for Logopedic, Phoniatric, and Audiological Services in Vienna. She is also ENT and phoniatrician in private clinic. And may I have the next one, please? And well, as you see, Berit is a very good author and well-known co-author of these two very important textbooks, Voice Diagnostics, Tracheotomy and Care of Tracheostoma. She has several international and national publications, and of course, she assists in a very frequent way to all the international and national conferences and workshops. Her interests are in diagnostic and therapy of laryngological disorders, occupation-related vocal disorders in the field of neurolaryngology. Amazing. She is vice chairperson of the clinical division of phoniatric logopedics at the Department of Otorhinolaryngology at the Medical University of Vienna since 2007. She is chair of the Austrian Society of Logopedics, Phoniatrics, and Pathaudiology since 2014. She is the vice chair of the Austrian Society of Music and Medicine since 2010. She belongs to different international and national associations, and she regularly performs as a solo singer and supports a number of charitable projects that deal with life and dealing also with illness. So we shall enjoy her presentation. Thank you, Berit.
Dear Professor Chavez, dear Eugenia, dear colleagues all over the world, it is a great pleasure for me to join this virtual meeting today and to spend part of the weekend with you. The topic of my presentation will be hypofunctional dysphonia versus dystonia in singers. My name is Berit Schneider-Stickler. I'm a laryngologist and phoniatrician from the Medical University in Vienna, Austria. I would like to start into this little presentation with a rehearsal presentation from the theater at the Wien. And it should just give you an introduction why it is sometimes important even to join rehearsals, performances, to learn more about our patients, to learn about their problems, and to learn more about the being on stage situation. The patients usually contact us because of voice problems. If it is an organic situation or organic dysphonia, then sometimes it is easier to help our patients. In case of inflammation, we can give medication. In case of any vocal polyp nodule, we can consider surgery. But the more complicated issue is if it is a functional dysphonia. Usually our patients have hyperfunctional voice problems. Depending on the place where you are, you sometimes call it also muscle tension dysphonia or muscle mysiodysphonia. All of you know that the functional dysphonia can either concern only the singing voice with a normal speaking voice, then we call it dysodia. And functional dysphonia can lead to phonation-associated vocal fold lesions. Here also an example. Why we have to consider functional dysphonia as the beginning of maybe phonation-associated vocal fold lesions. Usually we can observe two biomedical courses for development of these vocal fold changes. You can either observe hard clashing of the vocal folds due to excessive muscle tension with hyperfunctional vocalization, or you can have an increased flow rate of the exhaled air with an increased Bernoulli effect. Both causes can lead to mechanical tissue overload with tissue remodeling. And pictures like these we see on a regular basis. A young soprano with her first Traviata production last autumn, and she came with acute voice problems after phonotrauma, and you could see here a hemorrhage of the right vocal fold with the contact lesion of the left side, and even after 1 week of voice rest and combining medication, there was still a little telangiectatic vessel alteration of the vocal folds. So, but here we have already to consider hyperfunctional voice use. And the functional or the dysfunctional situation in our singers is even more of interest if we observe excessive tongue tension, excessive laryngeal tension, like here in this patient in the middle, or even difficulties with the passaggio and the singing register shift. Sometimes you see asymmetric muscle tension in the extrinsic laryngeal muscles, like in the right hand side. You see the shift of the larynx to the right side. The promomadami was completely shifted to the right side. Here we looked for dysbalance of the muscle tension situation. And during my period of experience, what is over 20 years meanwhile, I have more and more singers with very special, sometimes dysphonic voice problems. Here an example, my case number 1, it was a female singing student. She reported on having voice problems in the sense of deterioration of voice quality since March 21, and she mentioned that only the singing voice was affected, sometimes with voice breaks, sometimes with tremble, and sometimes also with pain in the throat. She reports that she was psychologically and mentally stressed at the time of the first occurrence, and the voice problems seem to occur especially about the frequency of F1. You can see here that the voice problem was independent from the vowel, and what you also could see that the expected lengthening of the vocal folds did not appear. She shortened the entrance of the larynx, of the editors larynges, and this was my main symptom. With the question, what could it be if vocal instability cannot fix the technical problems? The patient received vocal therapy, she went to several vocal pedagogists, and nobody could solve the problem. And so I went into the literature, and I think most of you already know that you can even have a focal task-specific dystonia in singers. And we call this singer's dystonia. What does it mean? We learned from other performing artists about these task-specific dystonia. We know them from the piano players. They can develop hand dystonia. We know it from the brass instrument players with the embouchure dystonia. We know it from drummers with the lower limb dystonia. And also singers can develop in their career a task-specific laryngeal dystonia that occurs only while singing. The singer's dystonia is, of course, a very rare neurologic disorder that initially confined solely to the singing voice and combines aspects of the focal task-specific dystonia found in instrumentalists. The involuntary contractions of specific muscles or muscle groups are characteristic for even the singer's dystonia. Like already said, it is only for the singing voice, not for the speaking voice, and thus it is different to the typical spasmodic dysphonia. The symptoms of the singer's dystonia include cracking of the voice at a particular pitch, instability at a particular register, difficulties in producing notes at a particular pitch. And I would like to go further with the second case. She was a professional singer with 10 years of stage experience. The voice problem started 2 years ago in the middle register, especially in the transition range from chest to head register. She complained on intonation problems and she could not reach certain pitches, although she had a perfect hearing. We performed EMGs of the intrinsic laryngeal muscles and also of extrinsic laryngeal muscles, and we here diagnosed also a singer's dystonia. Completely different voice sound like case number 1. And the second video here, we palpated the hyoid bone because we assumed a dystonia in the thyrohyoid muscle. So, with these two cases, very quickly, which therapy would you recommend here? Yeah, of course, we consider voice rest. What I learned from my patients so far is if you consider voice rest, then it is not only for 1 or 2 weeks. You have to consider voice rest for months, for half a year, and maybe even for a year. The longest period of a tenor I had in my experience was 3 years before he could return to stage. Of course, we consider speech therapy, voice therapy. We concern even the vocal pedagogy. But if you only focus on voice technique, you can even cause a deterioration of the voice. Yes, we also work together with physiotherapists, osteopaths to consider relaxation of muscles. But what else can we do? We can think about pharmacological intervention. We can even think about Botox, botulinum neurotoxin, but in singers this is not easy to use. And at the moment, one of our projects of our neurolaryngology working group in Austria, we even consider superficial electrical stimulation of the larynx. We put the electrodes, the superficial electrodes in front of the larynx, and we use a microstim device for the application of the current. The impulse duration is between 0.15 to 0.4 milliseconds, and the amplitude should be between 4 and 8 milliampere. We treated these two cases I presented this morning here with superficial electrical therapy, and at the moment they report an improvement of voice quality. Of course, the voice is still not perfect. But to summarize my very short presentation, I would like to conclude that hyperfunctional dysphonia and deficits in vocal technique must be clearly differentiated from singers' dystonia. Intensive vocal and logopedic interventions in singers' dystonia can even lead to a worsening of the symptoms. So far, we don't know causal therapies for singers' dystonia yet. And in the case of a singer's dystonias, please consider a longer stage break than only few days or a few weeks. Botulinum neurotoxin is highly risky intervention for voice professionals, and at the moment even the superficial electrical laryngeal stimulation can be recommended in singer's dystonia. Herewith, I would like to thank you very much for listening and for joining the COMET virtual meeting.
Thank you very much, dear Berit. It's a great presentation. And as you know, we shall discuss in the live discussion. Thank you very much, Berit. And I welcome our dear friend, Professor Dr. Antoine Giovanni from France. He is ENT professor from Marseille, the university assistants. He is also working in the public hospital of Marseille. He has been in the ENT department at the University of Conception. He made his career in medicine in the faculty in Marseille in 1985. And he has a mention très honorable because his dissertation about treatment of laryngeal cancer was with a special prize, Bushara, in 1986. He has ENT certification and head neck surgery certification, both of them, one of them in 1988 and the other one in 1997. He has a PhD from Aix-Marseille University in 1998 with the thesis about contribution for a multiparametric protocol of objective evaluation of dysphonia, also with mention très honorable. The next one, please. And this is Wonderful. And he also made an habilitation about making a special research as research professor in 1999, also at the University of Marseille. He has been ENT professor since 2000. He is co-responsible for Laboratory of Audiology and Phonology Clinic from 2004 to 2008. He has been coordinator of the University Department of Speech Therapy, also at the University of Marseille. And he's responsible of the POP group, oh dear Antoine, Physiology and Speech and Voice Organization, and Laboratory, Parole and Language since 2008. And of course, I cannot read all the list of publications because after 2,131. Here. So as you know, we love our dear COMET member, Professor Antoine Giovanni, and we would enjoy the working channel of our video endoscope, a path towards a soft interventional laryngology. Thank you, Antoine. Please enjoy.
I'm very happy to present this lecture on the impact that working channel video endoscopes has had on the care we can propose now for singers. The modern video endoscopes can indeed be equipped with a 2 mm working channel. This diameter is sufficient to introduce a whole set of instruments, including retractable needles, biopsy forceps, laser fibers, and others. These procedures are not really novelties, but many surgeons began more than 10 years ago, sometimes more. I would like to mention Marcus Hess, in particular in Germany, but also Lucian Celica in the US or Andrea Ricci Maccarini in Italy. They are far from being only early adopters. I must confess that as a French surgeon, I had been impressed by Marc Bouchaillier, and I am still convinced that microlaryngoscopy under general anesthesia is still a safe and performant procedure. But the worldwide development of in-office surgery, for many reasons, leads to consider differently some situations. In particular, the question of the relative place of laryngeal microsurgery and in-office surgery remains relatively difficult to systematize. This is why today I'm happy to present and discuss a few clinical cases for which in-office surgery seems to us to have provided an additional solution that we didn't have before. The first case I would like to present is a 51-year-old female patient, formerly singing teacher in Paris, who came to settle in the south of France. She had been having vocal difficulties for about 1 year, and especially in high tones. When we received her, she presented with vascular-like lesions, with an appearance of an angiomatous polyp at the middle third of the right vocal fold, and some ectatic lesions on the two vocal folds. For this patient, we decided to offer in-office surgery using the TrueBlue laser, which is an angiolytic laser extremely adapted for this procedure. We started with additional local anesthesia by injection just below the small polyp. Then the laser fiber was introduced into the working channel and brought under visual control until it came into contact with the lesion. After that, a 2-day voice rest was prescribed, as well as a recommendation of vocal moderation during a couple of weeks. And we gave her an appointment for a follow-up consultation at 1 month. At this time, the vocal folds looked quite satisfactory, as seen here, with the disappearance of the polyp, and above all, recovery of a quite normal stroke vibration. Encore plus fort. So, for this patient, the gamble paid off. We managed to solve her voice problem without microlaryngoscopy, without general anesthesia, and almost without interrupting her professional activity. it seemed to us that we had really answered their question. It can be the same with some emergency cases within the framework of a global care. For example, I'd like to present the case of a 54-year-old classical tenor singer. The very first time I'd seen him was some months ago for an hematoma of the left vocal fold. We can clearly see here the left vocal fold, with this hematoma at this time, and observe as well a small polyp at the surface. Of course, we had recommended a vocal rest, which had been effective, but the patient happened to return a few months later. Important thing? It was 3 weeks before starting rehearsals for a new production of Carmen, in which he was enrolled to sing Don Joseph. At this time, he was suffering of some kind of discomfort in the high tones and was asking if something was left of the hematoma or the polyp. And effectively, we found this small angiomatous polyp in the middle third of the left vocal fold, which actually caused a vibration defect at the mid-third of the fold. We understand that in high tones, this lesion can be the cause of a certain vocal dysfunction. Time was missing for microlaryngoscopy. We had only 3 weeks ahead, and we decided to propose an in-office laser treatment. Here is a video of the procedure. True blue laser was used in the contact mode. The patient resumed singing after 48 hours, and here is the control after a week.
Moi, du ressenti que j'ai, je pense pouvoir travailler normalement. J'ai plus d'altération à la voix, j'en ai plus détecté. La voix chantée.
Clinical cases of this type are now relatively frequent and seem opening new perspectives for the care we can offer to our patients. But I think we should discuss them. The current question is precisely to choose which patients can benefit from these in-office techniques and for which patients it is still preferable to offer microlaryngoscopy under general anesthesia. Actually, patients are generally interested by these in-office procedures. They identify as lighter. But we must not forget that the surgical procedures, whatever they may be, even by laser, even under video endoscopy, are not insignificant and are not always safe for voice. To illustrate a bit further my talk, I would like to present the case of a young woman, in the same time primary school teacher and jazz singer. She presented with an intense vocal fatigue when teaching or singing, and a moderate roughness. During the examination, we found these unilateral lesions very suggestive of an angiomatous polyp, and we proposed a treatment by speech therapy. But the vocal difficulties persisted, and so did the polyp. And finally, the decision was made to offer true blue laser treatment. The laser was also used on the basis of usual settings of 4 watts with an emission time of 20 milliseconds. But after 20 days, as in here, the result was not yet satisfactory, with a significant vibration defect of the treated vocal fold, and as well a significant glottal leakage. It took 45 days to obtain a satisfactory recovery of the vibration, and therefore an improvement of the vocal possibilities. This case illustrates well the caution that we must keep in the indications, because some complications with persistent abnormalities of the vibration can occur even after an in-office procedure. We must not forget that in the term of in-office surgery, there is a word surgery, and the greatest caution must prevail. I will be very happy with the comments that the friends of the Comet can make on this particular case, and to know what rules they apply when choosing between in-office surgery and microlaryngoscopy under general anesthesia. In-office surgery does, of course, not stop at the treatment of polyps and nodules, and I would like now to open another chapter concerning vocal fold cysts. The situation is not uncommon in singers, but when there is a cyst, the surgery, often enough, leads to significant vocal problems in the postoperative period. The question is therefore, can these patients benefit from in-office surgery to try to reduce the consequences of surgical procedures? The first patient in whom I considered this treatment was a 62-year-old man, a senior executive in the industry, who was also a very good amateur pop singer. He presented with this cyst, probably of a mucoid nature, at the free edge of the left vocal fold. And we decided to offer a treatment by simple puncture of the cyst in in-office surgery. You can see in this video the puncture itself, which was very simple and painless. The functional result was as well excellent. And after a few days, the stroke vibration had recovered in a very satisfactory way. With my group, Alexia Mati and Ralph Haddad, we discussed a lot this case, and we agreed that it might be worth trying to offer this option among the other treatment options. It's obvious that such a puncture cannot permanently remove the cyst, but it can reduce the tension inside and offer respite to patients while waiting, for example, to find a suitable moment in the agenda for the regular microsurgery. Now, for example, is the case of a 46-year-old female patient, street artist, who presented with relatively severe hoarseness and intense vocal fatigue during her shows. She presented with a cyst of the left vocal fold, very suggestive of an epidermal cyst. With her, we decided to try a puncture. The result was quickly satisfactory, with a resumption of his show activity after only 2 weeks, which would probably not have been possible with conventional microsurgery. Even in case of an excellent result, the question remains of the long-lasting or not of the result. As we do not remove the shell of the cyst, it's more than likely that the cyst will fill again after a few months, after a few years. However, from my opinion, this probably doesn't detract from the interest of this in-office option, which, for example, makes it possible to better choose a time for a conventional microsurgery. For example, when the patient is able to organize himself to be away from the stage for 5 to 6 weeks. More generally, our experience confirms the value of the conservative approach allowed by in-office surgery, which is gradually taking its place among the various therapeutic options for our singers. As I said, I've been more than happy to present this lecture in virtual front of the Comet family, and I'm eager to hear now your expert opinion. Thank you all in advance.
Thank you very much, dear Antoine. This has been great presentation, and we shall discuss a lot about all what you were telling us today. And now it is my pleasure to present the physiotherapist, our Comet member, Carles Exposito from Spain. He's bachelor in physiotherapy from the University Autónoma from Barcelona. He is trained in 2011 in professional and artistic voice mainly physiology of the singing voice with Alexander technique also. He has been studying in performing arts medicine at the Foundation of University Medical from Arts in Montauban, France. In 2013, he was trained in music physiotherapy at the Center of Prevention in Arts Escénicas in Barcelona. 2014 until 2017, he has been trained in posturology at Madrid, trained in voice and theater physiotherapy in the Center of Prevention in Arts Escénicas in Barcelona. In 2015, he trained in dance physiotherapy at the Center of Prevention in Arts Escénicas, also in Barcelona. In 2014 and 15, he was also trained in physiological change in Method Busquet in Brussels. 2021 to 2022, he made a specialization on rehabilitation and perfectioning the professional spoken and singing course in the University of Alcalá in Madrid. 2020 until 2021, he made cervical maxillofacial dysfunctions and laryngeal manual therapy, osteobox. And in Paris, in 2019 to 2020, he made special manual techniques for singing at Centre de la Guarda in Alps in Lyon. And Carles also has an MD degree in advanced theater study at 2019. He's also associated teacher at Music Conservatory of the Balearic Islands, also in Spain, and associated teacher at the University of the Same Place. He is at the moment president of the Performing Arts Medicine of the Spanish Association. He has been lecturer in many, many parts, and he is part of the voice research team ProElJet with many of our dear COMET members. I would like to say hello to Alfonso Barragan, to Marco Fantini, Silvia Capobianco, and Ana Gloria Ortega, and also to many of our guests, Adriana, Aurelio, Laura, Marcela, Marisabel, Vivian, Jessica, Maria del Carmen, Claudia. So let's enjoy. Can we think about a nerve compression syndrome to affect the voice? Let's hear Carles. Thank you, Carles.
Hello, everybody. Hello, my dear colleagues of COMET. I'm so pleased to be here sharing my thoughts, and I hope that they are going to be useful for you. Let's try to share my slide. It should be working. And so, can we think about the nerve compression syndrome to affect the voice? I am Carles Exposito. I'm a physical therapist specialized in performing arts. I work with the ProEL method and the larynx manual therapy on my own office in Mallorca, in Spain. And meantime at the Conservatory of Music of the Balearic Islands. So I used to work with professional voice users, singers, who have not really voice disorders. I am not working on the voice pathology, but I'm working trying to help them improving their feelings and sensations. And for this, I arrived to the point where several times, or usually, I ask myself, why do my patients improve with manual therapy? Well, is that because I'm having an effect on the muscle, on the joint, on the nerve? I would like to think that having an effect on the nerve could be very useful because it's a big controller of the system. So for this, we have to do first a remind on neuroanatomy of the larynx. There is a lot of controversy on that stuff, and the last researchers prove that recurrent laryngeal nerve and superior laryngeal nerve are both sensitive and motor, a big important thing. And another one is that the superior laryngeal nerve originates at the inferior ganglion of the vagus nerve. It leaves the skull on the jugular foramen, so it's not really a branch of the vagus nerve, even if it arises from it. And then the recurrent laryngeal nerve originates really as a branch from the vagus nerve. It makes its curve on the right side after the subclavian artery, and on the left side on the aortic arc. And after doing its curve, it's called the inferior laryngeal nerve. Important just to localize them. And we're going to see several important things that maybe we need to know. The superior laryngeal nerve, it splits in two branches, the internal branch and the external branch, before it pierces the thyroid membrane. It is made by the internal branch of the superior laryngeal nerve. It pierces the thyroid membrane, and I say it again because it's important. We are going to see a bit later. This nerve it supplies to the interarytenoid muscle and the posterior cricoarytenoid muscle, and it collects many sensitive information. This internal branch, it makes its anastomose with the dorsal branch of the recurrent laryngeal nerve, which is also sensitive and motor. And the external branch of this superior laryngeal nerve, it runs down, laying on the inferior constrictor of the pharynx. Important to note, just to localize them, we can see here on the picture of the right, we see this internal branch of the superior laryngeal nerve, which is piercing this membrane. We see the external one. We don't have the muscle there, but we can see it, and it arrives to the cricothyroid muscle because it supplies to it, not just to it, also to the inferior constrictor of the pharynx. But its main activity is for the cricothyroid muscle. And here we cannot see it, but on the bottom we see this recurrent laryngeal nerve and this branch who goes to the back, and it's going to make this anastomose, to do this Galeno anastomose between the recurrent and the internal branch of the superior laryngeal nerve. We can see in these pictures several connections and different parts of the nerve. These pictures are taken from the doctoral thesis of Carlos Martín Oviedo. We can see in other pictures the trajectory and how the nerve runs on this area. We know that the recurrent one is supplying to all the muscles, all the other intrinsic muscles of the larynx, but we have observed, and that's the work I have been reading, of this doctoral thesis and other works. There are many connections between the nerves, between the recurrent and the internal branch, the recurrent and the external branch of the superior one, from the internal branch to the external branch, and to the nerves from the both sides, the internal one, the recurrent one, and that can give an explanation on why do we find different positions of the vocal cords when there is a paralysis of this nerve. It's important, again, where do we find these nerves? So the external one, we said that it's laying along the inferior constrictor of the pharynx, so it's quite easy to palpate and to be injured on the surgery. So it's so important, and I give maybe a point of light. It should be very, very useful to work on ultrasounds and echography to identify and localize all those nerves and all their particularities on each subject. Where do we find this internal branch of the superior laryngeal nerve? Well, that's quite easy to localize, a place where it almost pierces this thyroid membrane. So it's with a difference on 2.61 and 1.65 millimeters of difference but it would be around 12 millimeters from the superior edge of the thyroid, 9.34 millimeters from the inferior edge of the hyoid bone. And when we have this part on the head, then we have to find the thyroid muscle to localize its posterior edge, and it's around between 10 and 90 millimeters from this posterior edge of the thyroid muscle. And let's see this image. On the regular endoscopy, we can see here on the side that there is a structure who is not stretching. It doesn't allow as much movement and it gets tight. So we can think that this is, sorry, if I can point it well, we can maybe think that this structure is the internal branch of the superior laryngeal nerve. That's important. It's so superficial there inside that we could think, why not? With all the inflammation processes who are happening on professional voice users, it could be a place where the nerve can be compressed and trapped. Why not? Where do we find the recurrent laryngeal nerve? Well, it's really very close to the cricothyroid joint, so we can palpate it quite well also when we go doing retrolaryngeal techniques, and it is so close that it's a place where it can be entrapped also. It can be compressed not just because of the joint, but it can be compressed also by the inferior constrictor of the pharynx. All this, why? But what's happening? It's not just this. How is going to influence in all this the pharyngeal plexus? We have many muscles who are regulated and supplied by the pharyngeal plexus. So this pharyngeal plexus is collecting sensitive information from the oropharynx, the laryngopharynx, by the 9th and the 10th cranial nerve, but also it's supplying to all pharyngeal muscles except the stylophoryngeal one. And that's important because not just this, but the cervical plexus is quite related on this area. All these muscles can parasite, can affect the normal position of the larynx, and when it goes up or down, these structures, these nerves are not going to run the same way. So it's important to think on structures who can entrap and compress nerves, extrinsic ones. You can say even maybe say structures who are a bit far but have a big relationship on there, and then the structures who are really on the area and can give also an effect, a symptom or something. As a physiotherapist, in many parts of the body, we study possible neuropathies which are originated by a nerve compression, a nerve entrapment. Where? On the proximal emergencies, where the branches are very superficial and can be externally compressed, where nerves pierce muscles, and where the nerves pass between a hard structure as a bone or a cartilage and the muscle. So we have found several places also which are on our point of interest. The main symptoms of a nerve compression are paresthesia, hypoesthesia, numbness, pain, weakness, or loss of dexterity, tiredness, or heaviness. Well, on the voice environment, we can say that a tired voice, maybe not as much on the pain, but also on problems on regulating the pitch, or also when we are having problems on the quantity of closing the vocal cords. Maybe too much, maybe not enough. So with all this, can we think about the nerve compression to affect the voice? That opens new perspectives, working on the larynx manotherapy in a different way, the dry needling, the neuromodulation, using ultrasound and echography as a regular thing that we should do. I have checked many articles that you can find there, and for this, I thank you for your attention. So with all this, I would like to say one thing. That's a point of view of a physiotherapist, but really the very important thing would be having a team on helping from one to each other on how to manage, how physiotherapy can help on this, and how phoniatry and speech and language pathology can help me on understanding this and trying to putting everything on order. So thank you so much for your attention. See you. Bye-bye.
Thank you very much, Carlos. We are having some small problems because in our group of attendees, we have several COMET members. Professor Jürgen Wendler, I don't know if you are still there. Please, the COMET members who receive an invitation to click panelist, please do click, and then you can come to the panelist group that is the COMET members. So I don't know, Carlita, if you can find Professor Jürgen Wendler, that can come with us, and also Marco Fantini and Alfonso Borragan and Ana Gloria Ortega. Carlos is already there. If you can put them in panelists, because when we are looking at the videos, it is not possible. So Carlita, shall we go on, or shall I wait a little bit? If you find Professor Jürgen Wendler.
Yes, I already sent them the invitation, so if you can accept it.
Okay.
Please.
Okay, so let's go on. And now it's the turn of our tributes. As you know, in Collegium Medicorum Theatri, since 53 years, we have had many wonderful members that have done and given a lot of experience and creativity to the artistic voice. And so we are going to make this small tribute to two of them. The first one is our dear Professor Nobuhiro Ishiki, and Yakubu Karagama, also COMET member, is going to make a short presentation as a tribute to late Professor Emeritus Nobuhiko Ishiki, 1930 to 2022, the father of laryngeal framework surgery. Dr. Yakubu Karagama from the United Kingdom. Thank you very much, Yakubu. Please enjoy. And we have to thank Ishiki Nobuhiko a lot of things for the artistic voice. We think of you all the time, Nobuhiko.
Hello. It gives me a great pleasure to give this tribute to the late Professor Nobuhiko Ishiki, who undoubtedly will be seen as the father of laryngeal framework surgery, who sadly passed away in his hometown in Kyoto in August 2022. Professor Ishiki graduated from Kyoto University Medical School in 1954. After that, he spent 2 years at UCLA at Dr. Havans von Leiden's laboratory doing laryngeal research. When he returned home, he performed intensive research in the mechanism of phonosurgery using excised larynx at the Kyoto University, and he was also an instructor in that department. He was later on appointed as an associate professor and then the professor in that department.
Dr. Ishiki discovered through a research paper by a Dutch physicist that a physical phenomenon was related to the vibration of the vocal cords.
Now,
なん
there
で
is this
そんなにこう空気が来たら声帯が振動するかというと、初めは弾力、ゴムバンドでこうやってると同じように弾力で元に戻ってこう振動してると思っとったんですが、そうじゃなくて、ベルヌイ効果って気流が流れると陰圧ができて、そして声帯を吸い込むということの方が大切だということが分かって。
When I first met Professor Ishiki in 2015, I conducted an interview with him, and he said to me he actually wanted to be a physicist, and it was the work from Van der Berg that persuaded him to follow the medical line and hence the laryngeal surgery and research. And it was this particular video that I'm going to play next that he saw that gave him the idea of the Ishiki thyroplasty type 1, 2, 3, and 4, which has been named after him.
Yeah, he's gonna go down.
Here are the muscles that move the arytenoids in various ways. The posterior cricoarytenoid muscles are these large ones which cover much of the cricoid plate. They are called posterior because they are at the back, and they are called cricoarytenoid because they arise from the cricoid and are inserted in the arytenoids. With attached threads, we can simulate the action of these muscles. We shall do the same with all the others as well. When the posterior cricoarytenoid muscles contract, they separate the arytenoids with a complex movement, largely rocking. Joining the arytenoid cartilages at the back are three interarytenoid muscles. On the surface are two small, inconspicuous muscles crossing each other to make a letter X. They are called the oblique arytenoid muscles. Beneath them, running from side to side, is a larger, much more powerful muscle called the transverse arytenoid muscle. When these muscles contract, they draw the arytenoids together. The lateral cricoarytenoid muscles can now be seen. They are called lateral because they are at the sides, and cricoarytenoid because they arise from the cricoid here and extend along the upper edge of this cartilage to be inserted in the arytenoids. Notice that these muscles attach to the muscular processes of the arytenoid cartilages. When the lateral cricoarytenoid muscles contract, the muscular processes are drawn forward. This results in an interesting adjustment of the vocal processes, which we shall see better in another position. We shall look down on these parts in much the same direction as they are seen in a laryngeal mirror. We observe the movements of the arytenoids as each pair of muscles contracts and exerts its pull. The posterior cricoarytenoid muscles separate the arytenoids with a rocking motion, and the interarytenoids draw them together again with a rocking and upward gliding movement so that the apexes meet. The lateral cricoarytenoid muscles do this, rocking and gliding. The gliding movement may have a rotating component around the upper or lower corners of the cricoid facet. We notice that the muscular processes are drawn forward and the vocal processes contact each other. When both the laterals and the interarytenoids contract, there is firm contact between the arytenoid cartilages like this. These movements will become more meaningful when we see the vocal folds in place. For this, we need a thyroid cartilage. We are now going to apply air to our specimen and observe the vibration of the vocal folds. It will be necessary to remove the horns of the thyroid to avoid interference with our thread. There is no longitudinal tension, so the vocal folds are loose and thick, and the sound will be that of chest voice. The glottis opens by contraction of the posterior cricoarytenoid muscles. Now the posterior cricoarytenoid muscles relax. Listen to the tone when both the interarytenoid muscles and the lateral cricoarytenoid muscles contract. Let us keep in mind the thickness of the vocal folds. We have been observing their behavior when they are like this. But now let us apply longitudinal tension. The vocal folds become thin and tense. The sound they will produce is a falsetto tone. At large degrees of longitudinal tension, we can expect small amplitude of movement. It is difficult to move the vocal ligaments away from the midline. Let us apply adequate medial compression and air and observe the vibration under normal light.
So if you understand this video, you will understand the whole of the Ishiki thyroplasty, type 1, type 2, type 3, and type 4. So after 22 years working as a career in laryngology, he moved to a newly established Department of Plastic Surgery as a professor there until his retirement at the age of 63. But actually, he did not retire completely from clinical practice. He opened up his private clinic called Ishiki Memorial Center. And in 2011, at the age of 81, he closed his clinic and joined the Hiroshima ENT clinic in Kyoto. And he operated there until he was 91 about. I was opportune to operate with him in Kyoto Clinic in 2015 and 2016. And this was him doing Ishiki thyroplasty type 2 at a conference that we had in 2016. So you can imagine at the age of 90, see how steady his hands are. I wonder how many of us will compete with us these days. He was a pioneer of surgery who developed a series of surgical procedures to improve the voice of patients with vocal cord paralysis, atrophy, after laryngeal trauma, pitch problems, and lately spasmodic dysphonia. Again, he developed this laryngeal framework surgery book, which he published back in 1989, and some of us will be aware of this book. And it was following this book that we came up with the classification, or rather he came up with the classification of thyroplasty type 1, 2, 3, and 4. Professor Ishiki organized workshops in Kyoto and all over the world. And in addition, he worked as instructor in so many courses, and this include a course in Groningen, Amsterdam, Mayo Clinic, USA, Ankara, Santiago, Korea, Mumbai, Sao Paulo, Riyadh, and in the last few years of his life, I was opportune to have it in Manchester, as you can see in the picture there, when he came over in March 2015 at the Manchester Phonosurgery course. His work has been recognized internationally. He was given several awards, such as the Gold Award, the Goldsmans Award for the Clinical Laryngeal Framework Research Work, Actor Prize, Ishiki Award by the Royal College of Surgeons of England, which has been named after him. He became honorary member of so many societies, and this include member honorary of the Hungarian Society of Otolaryngology, honorary fellow of the American Laryngological Society, Rhinological and Otological Society, to name a few. Ladies and gentlemen, Professor Ishiki was a real innovator, and through his creativity and enthusiasm and ingenuity, he has made a contribution to laryngology that a lot of us would have never seen before and will continue to enjoy and benefit from that for our patients. May his soul rest in peace.
Wow.
Thank you very much, Jacobo, for this great presentation. Sorry. And I would like to apologize with Professor Jürgen Mendler, because due to the two sections that we have, we could not change during the video recording to panelists. I think Ana Gloria is also missing because she needs to be in the panelist, Ana Gloria Ortega. I am sorry for this. And well, let's keep on with this show, as we know. Now it is the turn to make a tribute to Susanna Neidich. I met Susanna many years ago. She was wonderful, and we had several times wonderful together, parties, conferences, workshops. The last time I saw her was because Comet voted to make Susanna Neidich an honorary member of Collegium Medicorum Theatri. As we know, she is a lyric singer. She was a lyric singer, even though she is all the time with us, a speech language pathologist, singing teacher, and founding member of the Argentinian Voice Society. So please, Iris, let's make the tribute to our dearest Susanna Neidich.
Hello everyone. What a pleasure to see you, dear friends. Okay, we want to share with you that our friends, singer, speech therapist, and singing teacher Susanna Neidich passed away last January the 4th. She has been member of Comet for many years until her death. In 1971 and 1977, she and Dr. Segre organized 2 Comet meetings in Buenos Aires. In 2000, Susanna and I, with other colleagues, co-founded the Argentine Voice Society. Susanna was a great professional and human being, a great influence for voice specialists in South America. Comet, in its 50th anniversary, distinguished her as an honorary member during the World Phonosurgery Congress of the IAP and Sociedad Argentina de la Voz, celebrated in Buenos Aires in 2019. Now, Soledad Sacheri, the president of the Argentine Voice Society, will present a video in memory of her fruitful life. Thank you.
So now we shall hear the video of Soledad. Thank you, Soledad. Thank you, Iris. And thank you very much, dearest Susanna.
Today, I would like to honor the memory of Susanna Neidich, a visionary, a pioneer, and a creator of spaces for the exchange of knowledge and experiences. Few people have made such a profound impact on their discipline. Few have had such a profound impact on their work environments, their students, and their friends. Susanna embraced her profession with a universal spirit approach. Her training allowed her to take the stage of Teatro Colón with the same skill and enthusiasm she brought to her classroom and research. Her book, Principles of Phoniatrics, which she brought with Renato Segre, is a compendium of her love for science and art, her selflessness and her experience. It is a legacy for all voice lovers. Susanna discovered her passion for singing at a very young age. At the age of 14, she entered the opera of Teatro Colón in Buenos Aires, graduating in 1950 as a lyric singer. She went on to complete her studies in music and performing arts at the Academy für Musik und Darstellende Kunst in Vienna, Austria. She earned a master's degree in musicology from Brandeis University in Boston in 1955. And in 1958, she became a speech and language pathologist, graduating from the University of Buenos Aires, and later a licensed speech and language pathologist, graduating from the Universidad del Museo Social Argentino. She was awarded a scholarship by Vienna's Academy, where she began to sing oratorios and cantatas by Bach in Austria. In Salzburg, she participated in festivals and studied chamber repertoire with the scholarship of the Mozarteum of that city. In 1953 and in 1954, she was part of the cast of Teatro Colón in Buenos Aires, performing in The Rosenkavalier, Cavalleria Rusticana, and Sor Angelica. In 1954, she traveled to the United States, where she received a scholarship from Brandeis University to study musicology. Upon her return in 1956, she participated in the Premier Stravinsky's Barbara Martin's Les Mystères de la Nativité and Menotti's The Saint of the Bleecker Street at Teatro Colón. She performed under the direction of Carl Böhm, Erich Kleiber, and Jean Martinon, among others. In the United States, she sang at the Tanglewood Festivals and in Boston, accompanied by Aaron Copland and Leonard Bernstein. From 1967 to 1973, she held 2 chairs of vocal technique at the University of Buenos Aires and of speech therapy at the Universidad del Museo Social Argentino. She also belonged to the Professors Board at the National Conservatory of Music and at National School of Dramatic Art from Buenos Aires. She was a member of the Collegium Medicorum Theatri, the International Association of Logopedics and Phoniatrics, and the Argentine Logopedia and Phoniatrics Association. Susana and our dear friend Iris Rodriguez founded the Sociedad Argentina de la Voz with the purpose of generating a propitious space for multidisciplinary exchange in which to share knowledge about the science and art of the voice. Despite all of Susana's professional achievements and successes, her greatest legacy lies in the love and inspiration she instilled in her students and friends. Her passion for music and voice was infectious, and she shared it generously with those around her. She had a unique ability to make every student feel seen, heard, and valued, instilling confidence in their abilities and nurturing their artistic growth.
Thank you very much, dear Iris. Thank you very much, dear Soledad. And a wonderful life that show us the greatness of a personality like Susana Neidisch. Thank you, Susana. We love you all these years and all the life. Now it is a pleasure for me to make these 2 presentations of new members 2022. Now is the place for Jonathan Mark Fishman, and let's enjoy his own presentation.
Hi everyone, my name's Jonathan Fishman. I'm a consultant laryngologist from the United Kingdom, I'm a new member of Comet as of 2022, and I'm delighted to be part of this elite group of individuals from across the globe. So I'm a consultant laryngologist and I work in central London in the United Kingdom. I have a strong interest in voice disorders, especially in professional voice users. And I work at the Royal National ENT Hospital, which is part of University College London Hospital. We're lucky because we're centrally placed in London, so a large proportion of patients that we see come from the West End. I also have sessions at the National Hospital for Neurology and Neurosurgery, where I see patients with complex neurological disorders that have laryngological issues. I'm an associate professor of UCL and also a senior editor of the Journal of Laryngology and Otology. So this is where I was appointed 5 years ago now at the Royal National Throat, Nose and Ear Hospital, which was based at King's Cross. And we moved to our new facility around the time of COVID in 2019 to 2020. And this is our new facility down the road where I currently work. And you will see that the Queen opened up our new hospital in February 2020, just before the COVID pandemic. We have now established a Royal National ENT Voice Centre, which is essentially a multidisciplinary department where we have the surgeons, the speech therapists, and other allied healthcare professionals all working together within one organisation to treat patients with voice disorders. And as mentioned, a large proportion of our work is dedicated to dealing with patients that are professional voice users, namely singers, teachers, actors, and so on. This is our current group of individuals. Some of them you may recognize. You'll see that John Rubin in the middle there, and I'm delighted to be able to collaborate with him within the same department. And I've learned a huge amount from him over the years. This is the National Hospital for Neurology and Neurosurgery, also based down the road in central London. And as mentioned, I also see patients with complex voice, swallowing and airway disorders as part of their neurological conditions. I'm an associate professor at University College London, and my primary interest is treating and researching patients with voice disorders to try and improve their conditions. We currently have 2 trials ongoing. We have the long COVID study, which is a pan-European study looking at patients with with long COVID and voice disorders, and a second study that we're involved in, the TALGET study, which is looking at the use of alginates in patients with persistent throat symptoms, which is part of a multi-centre study across the UK. As mentioned, I'm a senior editor of the Journal of Laryngology and Otology, which is one of the 2 main journals within ENT journals within the United Kingdom. And this is a journal that was founded, in fact, in 1887. So has been going for more than 100 years now. Outside medicine, these are my 2 children. So I have to say that these little devils keep me particularly busy in my spare time when I'm not working. So I'd like to conclude and thank you all very much. As mentioned, I'm very excited and privileged to be part of this elite group of medical professionals, and I look forward to working alongside you all in the future. Many thanks. Bye.
Thank you very much, dear Jonathan. We are also very happy that you belong to our Comet family. And now we shall hear his own presentation, Julian McClarshon.
Hello, it is a great honour to be accepted as a member of Comet, and I thank Tom and Sarah Harris for their kind nomination. I am a consultant ear, nose and throat surgeon and laryngologist at the Queen's Medical Centre in Nottingham in the UK. I have experienced serendipity throughout my career, and I would like to take the opportunity to acknowledge a few of the many wonderful colleagues I've met and have helped me on my journey in voice. After qualifying at St Thomas's Hospital Medical School in London and doing my basic surgical training largely in the south of England, I was fortunate enough to be appointed as an ENT trainee on the Guy's and Lewisham Hospital's rotation in South London. During my first attachment in Lewisham, I met Tom Harris. Tom told me things about the voice that no one in my previous training had ever explained to me, such as the existence of the mucosal wave and how it was fundamental to producing voice. I was introduced to video stroboscopy, phonosurgery and multidisciplinary team working, meeting Sarah and Diana Harris and Jacob Lieberman. I was also introduced to Adrian Forsin, and through him had an introduction to acoustics of voice production and the value of electroglottography. In 1990, I moved to Guy's Hospital, where I worked with Ellis Dueck, who was an otologist and one of the pioneers in cochlear implantation. We had numerous conversations about voice production and speech reception. He was interested in the neurological voice and tasked me with buying some laryngeal equipment and gave me a budget of £10,000. We purchased the B&K stroboscope and rigid Machida laryngoscope with video recording equipment. I set up my first voice clinic at Guy's with a wonderful speech pathologist, Anne Whitehorn. A few years later, I rotated to St Thomas's, where I set up another voice clinic with Eva Carlson, a speech pathologist who had done her PhD on voice change following irradiation of the larynx, measuring changes using the laryngograph. Following this, I had a period in research at Guy's where I explored techniques for 3D representation of the mucosal wave using a structured light pattern. Although that element of the work was not successful, it did lead to the development of the original laryngograph's synchronized EGG stroboscope. In 1996, I was appointed as a senior lecturer at the University of Nottingham and a consultant head and neck surgeon at the QMC. I set up my third voice clinic with Fiona Robinson and Suzanne Slade. We were joined by two singing teachers, Lynn Wayman and Jane McDowell, in a few years down the line. I visited both Guy Cornu and Marc Bouchaillet, Bruno Coulombo and Romain Perouse in Lyon, and Jamie Kaufman in Wake Forest, all of whom were influential in my developing clinical practice and for whom I am extremely grateful for their help. I became president of the BVA and put on an annual training course in voice known as the Nottingham Voice Days. The focus was on core knowledge about voice production, clinical assessment and team working. It was supported by leading voice teams in the UK and invited international faculty teams, some of which are senior Comet members, to whom I'm greatly indebted. Our voice and laryngology team and service continues to grow and move from strength to strength, particularly with the appointment of my new colleague, Professor Reza Nourai, and 3 new speech pathologists. I've always had an interest in the singing voice and enjoyed the interactions with singers and singing teachers, particularly through the British Voice Association. However, I found a lot of the terminology confusing and had great difficulty linking what I saw endoscopically to the huge variety of vocal sounds that the human voice can produce artistically. In 2006, I attended a conference where I heard Catherine Sadlerlin from the Complete Vocal Institute in Copenhagen give a practical demonstration of the identification of what she termed modes used in singing as part of the CVT pedagogic model. It was very quickly apparent that it was easy for non-trained listeners like myself to identify these modes, and I thought it must be possible to identify common laryngeal settings, acoustic and possibly EGG correlates for these components of the singing voice. It took us another year to agree to do a study in which I metaphorically transported my clinic equipment to Copenhagen, and we systematically examined 20 singers to an exacting protocol, producing different elements of the CVT model. It took us another 10 years of research meetings in Nottingham and Copenhagen, poring over the vast amount of acquired data to identify the patterns which have led to numerous publications. We have performed further studies over the years, as needless to say, the original findings led to many more questions and nuances that needed exploring. Matthias Arn, a talented singer, singing teacher and postdoc researcher, joined the team in 2016. As an extension of the work, we have recently conducted a feasibility study on the application of CVT emergency aid to patients with muscle tension dysphonia due to ineffective voice production, and hope to be able to present the results of this study at a future meeting. I look forward to actively participating in this organisation, of continuing my learning and interacting with esteemed colleagues to further understand the performing voice in order to provide the highest possible care for elite professional voice users. Thank you.
Thank you very much, Julian. So, as you see, COMET is a great family with many interesting personalities who have been working in all the team situations that we need. That means artist, science, and of course, creativity. So please do not forget, COMET World Voice Day celebration will be 15th of April, and Isabel Garcia Lopez is going to moderate. Everybody is invited, and if you want to participate, please do it and let me know as soon as possible, because we are organizing the program. And this celebration is to the general population. It's of course academical, but with a very uneasy or easy language for all the population. And the next one, please. So we are going also to have several situations that are very important. We are, many of us are members of the Union of European Phoniatricians, and this Union of European Phoniatricians is having his 13th Congress in Antalya, Turkey. Professor Haldun Oguz, also COMET member, Professor İlter Denizoglu, and Ahmet Ageney, they are in charge of this wonderful Congress. And I just want to remind you that COMET family is having great day. This is April 29. Please come to Antalya. We are having at 1 o'clock, we are having Marcus Hess, also our ex-past president, Jacobo Karagama, Silvia Capobianco, Julian McLavash, Alfonso Borragan, İlter Denizoglu, Ahmet Ageney, and me in the first Past, Present, and Future of Artistic Work. And the second one, the same day, but at 3 o'clock, we are having a great panel, Treatment of Artistic Voice. Our dear Joseph Shlomi Hertia is being chaired. I'm the moderator again. And the speakers, also Alfonso Borragan, Orietta Calcinoni, Matthias Echtenat, Ahmet Ageney, Dirk Mürbe, Joseph Shlomi Hertia, Berit Schneider-Stickler, and Andrea Ricci-Maccarini. So we are going to have really a great banquet of COMET in this wonderful Congress that our dear Haldun, Ahmet, and İlter have made a lot of passion and enthusiasm and of course work to have this great Congress. And the next one, please. We are going to have as COMET, here you see some of the presentations. Jacobo is going to talk about superior laryngeal nerve palsy, Silvia about Western classical singing, Julian some acoustic and EEG observations in rough effects on singing, Alfonso about ProEL in acting and singing voice, İlter extended vocal hygiene and vocal ergonomics. I am talking about avoidance and neutralization of environmental harm in artistic voice, Ahmet about surgery of artistic voice, when and how, and me again in indirect phonosurgery of artistic voice. And the next one, please. And we are having this great roundtable about the treatment with all our dear members. So we are having really a very important roundtable to discuss about the treatment of artistic voice. The next one, please. And very wonderful, we are joining again our dearest Robert Satalov and the Voice Foundation group, who are really working as they have always made with a great effort and organization. We are having 31st of May, 8:30 to 12. We are having great presentations. Our dear Ron Scherer is going to be there with one of his wonderful students talking many things. We are finishing the program, but I really invite you to come because this is a small group in a very huge and interesting symposia from the Voice Foundation. And also the next one, the Voice Foundation invited us for a special panel, Emergency in Artistic Voice, and we are going to share with Isabel Garcia Lopez, with Liza Popel, Pete Wu, and Reynaldo Yasaki. We are going to be together in this panel, the 2nd of June, 10:10 to 11, in the great 52nd Annual Symposium of Voice Foundation. The next one, please. So, and of course, we are preparing our next academic session. Please do not forget, it's 1st of July, and it's going to be, until now, it's a preliminary program with Jonathan Fishman about what has happened in the 10 last year and what are the advances in artistic voice. Our dearest Ron Scherer, he's going to talk an overview of intraglottal air pressures that drive the vocal folds for normal or abnormal vocal fold motions. We have still some places, so please let me know if you want to present some of your great works. The next one, please, is the webinar. So everybody, COMET members, are invited to take part in this Saturday, 29 July webinar. This webinar is a COMET webinar to the world. So everybody is going to be invited. We are arranging some administrative and payments issues, but please do not forget. And if you want to be in this webinar, please let me know as soon as possible, because COMET Family Group is a very important group of experts in artistic voice. Do not forget that. And the next one, please. I try to be very quickly. Well, it's only some administrative. As you know, our dearest Joseph has been helping a lot. Now we are not yet ready with the new COMET in US, the bank account in US, and Joseph is helping a lot as always, and I thank you very much, dear Joseph. And the treasurer is Austin, as you know, so we shall let you know. We are a little bit slow, but we shall let you know on time. Until now, you can still pay in the old bank account if you wish. The next one, please. And as you know, the payment fee is COMET members 70 euros and the non-COMET members 30 euros if you want to join our virtual sessions. I thank you, all of you. And if you, Carlita, please open the videos that everybody can be a part of this picture, of this group picture. And I am very sorry that Jürgen has left us because of this technical problems. And I do love all of you. Offer, Andrea, Carles, Iris, Antoine, Ana Gloria, Soledad, Ron, Alfonso, Joseph, Very, Jacobo, Bruno, Isabel. And don't go, because we have the live discussion with all our experts that made great presentations. So please, Carlita, if you can take many pictures. So, and thank you very, very much to be together again in this Zoom meeting, even though it's a little bit long, but we enjoy very much the experts that presented today. So thank you very much. And let's come to the live discussion. Well, dear Berit, thank you very much for your wonderful presentation. And I would like to begin the discussion. As you know, please let me know if somebody wants also to make some comments or questions. And Offer has to leave. Thank you, Offer. So see you soon. Don't forget, 1st of July. And dear Berit, I wanted to ask you about your experience with the different electrostimulations, because in your very interesting presentation, you talk about the microstim. Do you have something to add about these electrostimulations? Because I think it is really very interesting.
Yeah, I would like to thank you very much for this wonderful webinar this night. We have almost 9 o'clock here in Vienna. So thank you so much for inviting all of us here. Yeah, this is really an interesting topic. I'm a member of the working group of the MED-EL research group, and we do a lot of stimulation, electrical stimulation in spasmodic dysphonia, in voice tremor, in vocal fold paralysis. And we got experiences with the electrical stimulation of the supralaryngeal nerve, and we also started direct stimulation of the LCA, and we started stimulation of the recurrent laryngeal nerve. And we realized that we can lower the extent of spasmodic character of a voice by applying the electrical stimulation. We did it with hooked wire electrodes, and we can do the hooked wire electrode stimulation only for a few days. And because of the good experiences, we decided to go further with the superficial electrical stimulation. And I think a year ago, we started with the electrical stimulation via surface electrodes. We cannot solve the dystonia problem yet, but we realized that the voice became much better and the difficulties and special extent of the singing voice became less. So we think we have here a contribution. We have not the solution yet, but we have a contribution to make the voice problem easier. So this is why we go further with the electrical stimulation.
This is very interesting, and may I open the questions or comments from the audience? If you have some comments, Jacobo, Isabel, yes, please, Isabel.
Hello. First of all, congratulations to Berit for this fantastic presentation. Thank you very much. And actually, I have two questions, if it is possible, if we have time. My first question is regarding your second case. You said you perform a laryngeal EMG in this case, and you said that you found a dystonia, I think on the left side, you said. And my question is, what is the pattern that you found in laryngeal EMG to say that there is a dystonia in this patient?
Good question, Isabel. Thank you for this question. I would say that dystonia is still an exclusion of other diagnoses. Mm-hmm. We learned that the spasmodic dysphonia is only for the speaking voice. But I have more and more patients with problems of the singing voice. They have completely normal speaking voice. And then you go into the detailed problem and you see that they can sing at a special range very good. So high singing, low singing is working, but there is some range of voice what does not work. And all the patients I have seen so far are completely different. And meanwhile, we perform the electrical EMG, or the EMG, I'm sorry, in all these patients. We do the TA, we do the LCA, we do the PCA, the CTA. And so we try to understand if there are maybe asymmetric innervation of the muscles. And what we could find is that the muscles are very often not in a symmetric stimulation by the nerve. We see asymmetric intensity of the motor unit activity in these patients in different muscles. And this is what we consider, that there is a special innervation of the laryngeal situation, maybe overexpression, overactivity. Yeah, so we know that in a maximum voice phonation, we have a dense interference pattern. But what if you have a more dense? I didn't expect that you can have a more dense activity pattern. But sometimes you see even at rest level, you see a very dense pattern in the EMG. And then you start with the phonation maneuvers and you see a very high amplitude in one muscle. So there is this, I would say, a hyperactivity of stimulation of these muscles. If you have another name, I would be happy to have another diagnosis, but I went into the problems of the performing art musicians. And if we consider the fingers dystonia, the embouchure dystonia in the brass instrument players, then I think it is very similar in our singers. And we have to consider that many of our singers have dystonic problems, and we always send them to do voice therapy, to do voice lessons with their vocal pedagogist. And this is what we should not do. We should not intensify the practicing of the problem. And this is what I wanted to mention here in my short presentation.
Mm-hmm. Thank you very much.
Long answer, I know. I'm very sorry.
And the second question, Isabel?
No, she already answered, because I was thinking about what is the key for the diagnosis, but she explained it very well. Thank you very much.
Thank you very much, Isabel. Yes, Ron? Yes, Ron?
Hi, Merit. Wonderful presentation. Thank you so much. Two questions, actually. Does the electrical stimulation actually improve swallowing behavior?
This is a question. We use electrical stimulation in the limit before the patient develops a swallowing reflex. So for us, the swallowing reflex is an exclusion criteria for application of the surface stimulation. Of course, meanwhile, we started another study to use selected parameters of the stimulation for treating the swallowing. I know. But here for these patients, we have to be in between the sensitivity threshold and the side effects threshold, like swallowing or any strep muscle activity. So we have to be in the window of, you feel it, but it does not cause any discomfort.
Interesting.
Somebody from the audience wants to talk.
This was just one question. There were two questions.
Yes.
What is this?
Yeah, I had another question. I think did you mention? I didn't take good notes earlier, but didn't you mention that in certain cases for the singing dystonia, you might wait a long time, a few months maybe, and find that there is improvement, and what would cause that improvement?
So now we go, Eugenia, how much time do I have to answer?
Well, I am sorry, but let me see. Yes, okay. I am sorry. Mexico will change time, so it is.
Just 1 minute. Just 1 minute.
We have all the time that you want. For me, is no limit.
Thank you. My most important experience was with the tenor. He was a member of the group of 10 or 12 tenors, very successful, and he came with the voice problem, and nobody could solve the voice problem. And then he decided to leave the stage, and he went into a physiotherapy program. And I think a few weeks ago, he came back to my office just asking if everything is fine. And I asked him why. And he told me, yes, after 3 years, I tried again to sing, and it works perfectly. And so he decided to go back to stage. And this is exactly my answer, even for these voice problems. The first case I presented to you asked me, how long should I wait until I return to stage? And without experience, I told her maybe 2 weeks, maybe 3 weeks. Meanwhile, I completely changed my mind. And if I have the dystonia in my mind as a possible diagnosis, I recommend to leave the stage and to avoid singing for minimum half a year, maybe a year. And this is what we learn from all the other musicians. If you even think about Lang Lang, it is very it's impressive. If you follow the career of Lang Lang, he has a dystonia of the left-hand side. And I was really surprised. He signed a contract with Sony, and Sony was thinking, how could they sell Lang Lang? And now he is presenting concerts just playing with the right hand with the with the second person. Now they have piano pieces for 3 hands. And this is what I really learned from the other musicians. And now I try to use all these experiences for our patients, for the singers. Before we tell them you should leave the stage forever. And this is what I try to learn.
Yeah. Well, maybe if it's just the left vocal fold, just have them phonate with the right vocal fold.
Ronald, great idea. I would tell them.
Yeah,
But honestly, I think that because of the intense voice use, you get an overexpression in the motor unit brain part. And the break and not using the voice in a singing style, a professional style, will help to reduce this over-representation of the motor centers of the brain. And that's why I think there is a chance to overcome the dystonia, but not by using the voice and not by continuing the vocal lessons, not continuing singing. Yeah, and this is very important. We have to tell them, take a break.
Yeah, on the other hand, dear Ron and everybody, I think it's also difficult to decide when to say to the singer, please stop, because I have some cases, very elite opera singers who had to stop the career because of some scars or things like that, because of laser, or because of surgery or another diseases. But for example, in the cases that you mentioned, it is not so easy to decide that. And also, you conclude also that sometimes if we over-exercise is more damage than help. So it is not so easy. I was thinking perhaps we can have some comments from Bruno or Antoine, Alfonso, Carles, Iris, about if you have some experience about leaving the singer without singing a very long time, Ana Gloria, and then that they become, as very patients mentioned, in a proper way of singing. But I don't know. Somebody who wants to comment something? Andrea? Bruno? Yes, Carles? Nothing? Alfonso? Okay. So thank you very much. Yes, Ana Gloria, would you like to say something? But open your micro, please.
I want to ask her, what did the singers do during the rest time? Did they not do anything? Did they make some exercises, not voice exercises? When you say exercising is not good for the voice, what kind of exercise is not good for that voice? For the dystonia?
Oh, okay.
So I saw something in the on the right. In your second case, I saw something on the right vocal cord. On the right vocal cord.
Yeah.
The right
but
arytenoid.
Honestly, even if you find an organic lesion, but then you hear the voice, then you see the vocal fold movement. Do you really think that this tiny little vocal fold alteration causes a problem? I say no. And very often, because of the dystonic problem, it is very little number of patients with dystonia. I don't want to say that every patient with a long-lasting voice problem has a dystonia, but we have to have it in mind. And what I learned from very close patients, that they develop over time because of the very excessive voice use. They want to solve the problem. They push, they use overuse of the voice. They develop even polyps, they develop nodules, they develop any kind of vocal fold edema. We are happy to see an organic lesion because we can do phonosurgery, we can solve this problem. But afterwards, they are not better. I had a tenor with the vocal fold polyp. I removed the vocal fold polyp. He was happy. He returned to stage, like everybody does, a few weeks later. But he could not solve the problem in a very high range. It was always a creaky, a break in a special passaggio area, and he could not solve the problem. So what should he do? The same. After many very, very bad productions and very bad critics in the newspapers, he decided to leave the stage. He went to a touristic bureau, so he just completely switched his life. He didn't sing at all. He went to the mountains, he was mountain climbing and so on, bicycling, whatever. And half a year later, he came back to stage, and it was a completely different voice. Yeah, so even if you take a break from stage, you should not even think about singing. Yeah, this is what I recommend in these cases.
Thank you very much, Mary. Thank you very much. And I want to ask Antoine about the recuperation, because it is completely in the same direction as Berit says, because sometimes we make phonosurgery. Of course, we have an integral diagnosis, and the results, even though surgically are very good, functionally are not good, even though the patient is under the integral universal diagnosis from vocal coach, singing teacher. Of course, he or she is a singer. So what is happening with the recuperation? Because in one of your cases, Antoine, it was really the first days, it was not so good, but after 45 days, it was good. So the question is to be together with Berit's presentation. What do you think, Antoine, in general, to discuss this recuperation, this recovery?
Yes, I understand the question. It's a very, very difficult question. Precisely, it's difficult to anticipate for the patient. Very often the question is, when can I sing again? When can I go back and sing? It's almost impossible to really answer, and it's very difficult to tell to the patient all the difficulties he or she has to front in the post-operative period. Actually, I have no answer to this question. How to anticipate the post-operative recovery? How to improve it? The best we can do is to operate as well as we can, and to order vocal rest for some days. The question, when I started to operate the patient under video endoscopy, was to try to minimize the impact of surgery on these patients, and to try to sometimes avoid microsurgery. So if we take the example of cysts, I try to operate the cyst as well as I can. I have been learned by Marc Bouchaillet, as many of us, and I try to do the same, to gently dissect the cyst from the vocal ligament, etc. But very often, mainly in lyric and classical singers, the recovery comes very lately, and we can anticipate 3 to 6 months out of the scene, maybe sometimes without able to sing, and we were wondering if it could be better to try to diminish the tension inside the cyst, not to cure the cyst, but simply to allow the patient to sing again very soon, not perfectly, not probably after the punction of a C, the patient is not able to sing at the scala. But all of my patients are not singing at the scala anyway. Very often jazz singers or pop singers do not need the perfect voice of a very perfect vocal folds. So sometimes I try to choose something between surgery, since I am unable to anticipate the result, and speech therapy. It seems that surgery under videndoscopy offers an intermediate path, an intermediate solution. But I went to this meeting, the COMET meeting, with more questions than answers, and I would be very happy to have the opinion of very good experts as Ronald or Bruno or Andrea.
Yes, thank you, Antoine. Yes, Ron?
Antoine, just a quick question on that last case that you had. Did you consider augmentation to kind of puff up that left affected vocal fold? It seemed to have a little less mass to it than you would want.
The very last case with a cyst?
Yeah, I think that was the case where you had a little difficulty time. It took a few weeks to get it back toward a normal looking, but still it had some lack of mass, I think. Would you have considered a little augmentation or something? No.
Probably I have to make some progress in video or in stroboscopy, since the result is very good, but on the video it was seeming yes, I understand what you mean, but the patient is completely happy with their voice.
What I learned from your discussion, I see the trend. You have the OR surgeries, and then you have the in-office surgeries. So it seems like the next step is just have at-home self-applied, laryngeal surgery. So if you could work on that, that'd be great.
Yes. Is somebody from the audience want to comment something? Because now we are talking about recovery of phonosurgery, and of course it is not so easy. Yes, Alfonso.
Yes, congratulations, Antoine. The images and the technique are excellent. Very, very, very well. Do you use the technique to put some substances in the lamina propria, for example, corticoids, hyaluronic, to improve the rehabilitation? Do you use this?
Yes, very, very often. Very often we inject sometimes steroids or hyaluronic acid, for example, in case of some of mass missing of vocal fold. We also inject in the case of a trial stem cells in vocal folds in case of scares. Yes, very often we inject different things. Again, it's another way to operate without operating, without destroying the lamina propria, without opening the vocal fold.
Yes. Thank you, Alfonso. Thank you, Antoine. So in general, well, we have the both options, indirect or direct. We have some equipments like rigid or flexible endoscope, which I do think that our trend is to be as cautious as possible, to be so conservative as possible, and to work in a team group, because I think this is very important. And of course, I was thinking when Berit made her presentation that all neurological things are not so easy. And now with the infections like COVID, we are also dealing with some dystonias. Thank you very much. And I would like to ask you three, Berit, Antoine, and Carles, and if you please tell me first, Carles, the option that you as physiotherapist can give to our phonosurgical patients, and if Berit and Antoine are using also for their patients physiotherapy? Yes, Carlos.
Well, that's a good question. I would say that, well, for my interest, I would say that it's very interesting to join or to include physiotherapists in a multidisciplinary team, not taking place to others, but just complementing. And how? Well, sometimes it's interesting because we used to relate physiotherapy to relaxation, but relaxation finally it's just something which doesn't last very much. We have another problem and we are not relaxed. We are not relaxed again. So maybe I was very interested on this electric stimulation, on how can we bring it further, maybe on a neuromodulation. How can, if we are just stimulating that nerves with needles and having another effect, that's the big thought that I have at the moment on how can we include modern physiotherapy, the physiotherapy of the 21st century, into voice disorders and helping to other professions improving. And for us, physiotherapists who don't work with voice disorders and voice problems, to open a new field on pushing a bit more. So I would say on maybe giving other information, so working on proprioception for disorders like dystonia can be very interesting to work, giving other sensations on how do a voice professional user is using his voice. And at the same time, maybe this neuromodulation, how can we understand it and how can it help? That's maybe a question answering another question, but yeah, that's my point at the moment.
Thank you, Carlos. And Berit, do you think it would be a good idea to use in this dystonia patient also extralaryngeal physiotherapy, or do you want to comment something about that, Berit?
Yes, thank you for this question. Honestly speaking, I would use the physiotherapy as long as I think that it is a hyperfunctional dysphonia. When I decide that it is a dystonia, I change my program. I have to completely change the program. But I'm very happy that you invited Carlos here in this audience, because I'm very happy that you, Carlos, presented the laryngeal manipulation. This is a very hard problem, even in Austria, to find cooperation with physiotherapy in treating voice professionals. When I send my patients to physiotherapy, most of the physiotherapists consider the neck, they consider the shoulders, the spinal column, the standing, the posture, whatever. But I had to train as a physiotherapist even to deal with the larynx. Nobody is even able to touch the larynx and even to manipulate. And I also went to Jacob Lieberman, I think 10 or 15 years ago, to London, and I was really so impressed about his manipulation of the larynx. I could not even imagine how he reached the posterior muscle just by palpating. But this was such a great experience that I really looked for a physiotherapist, even in Vienna. I sent her to Jacob Lieberman. She did the courses with him. And so we have a close cooperation, even with laryngeal manipulation for our voice professionals, Eugenia.
Yes, thank you. And Antoine, do you want to say something before we give the word to Ana Gloria?
As a surgeon, I'm not sure I'm the good speaker on this question. Probably Bruno more than me.
Thank you.
Bruno.
Yes, Ana Gloria?
Yes, I want to tell you that in Argentina, we always make laryngeal manipulation in almost all the patients. And there are many exercises we make without voice. And they are exercises, muscle exercises, that work on the voice, but not directly with voice. And they are very useful. Perhaps we may talk about those exercises another day.
Thank you. Well, I wanted to make this comment about the rigidity or the rectification of the cervical column, and also with bruxism, because many times the joint, the temporomandibular joint, and the rigidity or rectification of the cervical column are having problems with extralaryngeal muscles, and of course, it can be possible that they have some dysfunction in the intralaryngeal muscles. And my experience with the manipulation, we have to be careful. Of course, there are some persons that are already with a great expertise in this, but it is not a thing that we can handle all over the world and all over the time, because sometimes the patient or the singer, they try to manipulate also his or her larynx, and it can be dangerous. So it is not so easy. But I do think that we have to take care with the physiotherapist about the cervical column and about the extralaryngeal and the facial muscles, because they have an impact in the voice muscles also. I don't know, Jacobo, Isabel, Bruno, if you want to make, of course, Andrea, well, everybody, if you want to make some comments about that before we leave.
I just want to make a comment on my experience with singer's dystonia, because I've got a patient currently that I'm managing. I think I discussed it with some of our colleagues that we are on a different sort of forum. So I was recommended to give Botox injection, and I gave Botox 1.5 units into each side, and it didn't change anything at all. And normally when you give Botox 1.5 units, a lot of patients will have breathy voice. And I know it was at the right place because I did it by direct view, by transoral. So she came back again and I gave 2 units each side. And the voice was remarkable after that. And I'm hoping that I'll be able to present it here at the next one of our meetings in future. And the Botox is wearing off now. It's about 3 months now. And when she starts singing, she's struggling with that as well. Speaking voice is absolutely fine. Singing at low pitch is higher, but when she starts going up, the voice falls apart completely. So I've got some few videos that in the future meeting, I will present it to share my experience. She's coming back on Monday. I'm gonna re-inject her again because, again, the 3 months have gone, the Botox has worn off. So that shows that the Botox is making some difference. By the way, she's had extensive speech therapy. She's seen so many speech therapists, tried everything. She's rested her voice, not done anything, but still she couldn't manage it.
Thank you, Jacobo. Somebody else want to comment something about this very interesting issue? No? Well,
can you hear me?
Yes, Andrea. Yes, Andrea, please.
Yes, I would like to, many compliments also to Antoine. I'm very glad that you are a promoter of this flexible endoscope phonosurgery technique. And I would like to hear from Bruno, because when I was in Lyon, I met Jean-Blaise Roch, and he now is one of the promoters of this laryngeal manipulation. I would like to know something about him from Bruno, because he works in Lyon, like Bruno.
Okay.
Thank you, Andrea.
You have to talk.
Hi, everybody. Yes, in fact, in Lyon, we worked. I didn't work directly, but we worked with Jean Blaisotte and Alain Piron, who's a Belgian osteopath and developed the OsteoVox technique. And Jean Blaise and Alain teach the technique for several years, and Alain is still working and teaching this technique. I work a lot with physiotherapists and osteopaths, but not as independent people. They are a part of a group of with us, with speech therapists and physiotherapists. That's why, Eugenia, I understand you told that we must be very careful, but in this kind of groups, we are talking together, and we really make a sort of plan of a sort of organization. And you're completely right. It's not very easy for people, singer or not, to let somebody touch the larynx, and perhaps for a singer it's harder than for other people. So we work and we try to do this kind of team work and to be able. It's impossible to think that a singer who has voice problems since months or years has not developed muscle compensations and has make a different balance in his larynx and his in the body, and it's very difficult to think that if we take out a lesion, a polyp, a nodule, a cyst, we will solve the whole problem only with the surgery. Perhaps Antoine will not agree with that. And I would ask Antoine for the singer you showed what the cyst you did empty with the nasal fibroscopy. Did the cyst fill again after a few months or weeks?
Thank you, dear Bruno. So would you like to comment something? Or I close this session. First of all, dear Berit, it was wonderful to talk about such an interesting issue because we are seeing more and more neurological problems. It doesn't mean to be Parkinson or sclerosis or to be vocal fold paralysis, but the tiny details from the neurolaryngology. So it was wonderful to have your presentation. And dear Antoine, as always, you are an artist in phonosurgery, my dear, and I thank you very much. And of course, Carl has bring us many interesting details because all the muscles are all together and I deal with all these problems daily. So I sent many of my patients telling exactly which muscles, for example, for the column or from the cervical column, we need to treat. And also the other thing that it is very important is the posture. That we didn't talk very much about that, but the posture is very important, and also the dental movements or the closure of the joint. So I thank you, all of you, for being so late with us. And if you want to change the time, because Mexico had also a summertime change, but this year, because we don't need so much light like Europe or some other places in the world, we didn't change. So we have 8 hours difference from Europe. So I'm sorry about it. So just think that we are like in theater. That's why you are so late. So if you have some proposals, please do not forget, Comet members make Comet rich. So we have to work. Thank you very much. And I see you very, very soon in Antalya.
Thank
Ciao.
you.
Ciao. Ciao.